pronouncing your name. Yeah, these lab crowds are wonderful groups, and what makes them even better is the social aspect. You will build lifelong relationships with other folks that have Parkinson's disease. So highly encourage you to visit that booth. You also have white little cards in your folders. Feel free to fill that out, and we can put you on our mailing list, send you information on the Speak Out program, and connect you with them as well. So our next speaker is Khoo. Rehab team since March of 2018. He has 36 years of prior clinical experience. I'm only 31, so that's longer than I've been alive. So he knows what he's doing. He's worked and managed outpatient clinics and hospitals, inpatient care, long-term care, you name it, he's done it. He specializes in treating patients with Parkinson's disease, multiple sclerosis, EMJ treatments, mobility training, and more. Keith teaches several courses, both internationally and within the United States. He's been on the Physical Therapy Association Board of Directors in multiple roles for several years. He completed his undergraduate education degree at the University of Oklahoma, and he got his baccalaureate in physical therapy in 1985. So without further ado, I'd like to introduce Keith Khoo, everybody. Give him a round of applause.
Good morning. Thank you for having me. Thanks, Matt. Thanks, Bruce and Lisa. Thanks. Nice job. And thank you all for showing up, and your caregivers, most importantly. It's already screwed up. Yay. Oh, wanting me to connect to internet. I don't need it. All right. So balance. Let's talk about that a little bit. You have Parkinson's disease. Now what? If you haven't seen a doctor already, you need to, especially neurologists. If you have not started medical treatment, you need to do that, right? Do you have a diet? Do you exercise regularly? And then if you haven't already gone to a support group, you need to look at doing that, because that's going to help you understand this a little bit more. So the point of all of this is to educate, is to make sure you understand how to manage your problem. You are not alone. There are tons of people out there, 1 million in the US, right? That's, you'll see later on what date that was. There are more people with Parkinson's than with multiple sclerosis, muscular dystrophy, even Lou Gehrig's disease. And those are combined, by the way. Average age, 62. Can you have it younger? By all means. Younger people can get it, but it's less common. And here's the research that's related to that out there. So what are the symptoms? Your biggest symptoms are all the motor ones that you know of. There are 4 in particular. The 3 are most common, and the experience is different for everybody. So it's not always the same for each of you. So remember, you have a resting tremor, you have the bradykinesia, the stiffness and rigidity, and last but not least, why we're here to talk about balance. Other symptoms, and there are a host of them. These are your non-motor symptoms. I'm not going to go through that, but I think some of you already know that you have those, and how do you address them? You need to be talking to your doctor about that. So what are PDs? Just a review so you understand why, and I'll connect the dots as well. So remember that your neurons transmit your messages from one part of your brain to the other via a neurotransmitter. In this case, that transmitter is dopamine. So you have a loss of that ability. You have less dopamine production, and therefore being able to think the task and then do the task is not so easy because you don't have that transmitter present. Now, you also have difficulty in controlling movement as a result of that. So traditional view is that Parkinson's begins in the midbrain in the substantia nigra. And all of these are terms that you don't have to remember, right? There's a current hypothesis called the Brack hypothesis that suggests that Parkinson's occurs way before the movement symptoms occur. So Dr. Connor talked about constipation. He talked about smell loss. All of those have come on way ahead of the time that you actually have been diagnosed. So this affects the lower brainstem, progresses to other part of the brain as we go along. Non-motor symptoms appear before the diagnosis. We talked about the smell and your constipation. The good news is you're not moving around, you're not doing things, you're in trouble. So this is about to happen very shortly, I think, right? We're supposed to have the worst winter yet. Right? Remember that balance is not just a Parkinson's problem. Balance is for everybody in this room, okay? So here's it. Have you fallen in the past year? Have you had a feeling of motion, whether you're spinning or you're falling or moving your head quickly, changing your position? That means when you get in and out of bed, you feel unsteady. Have you felt uncomfortable trying to get around in the dark? Have you felt walking down a grocery store aisle or in the mall is upsetting? Have you felt that you just won't go where you want your feet to go? Have you felt a sense of unsteadiness that you are not sure-footed? Have you felt a fear of falling or stumbling? And the list is going on. Have you felt that looking at moving objects, such as on an escalator or looking out the window of the car, makes you queasy? Have you had difficulty keeping your balance as you walk on different surfaces, tile, carpet, grass, stairs? Have you felt a feeling that you are drifting or being pulled to one side when you're walking, or that people think you're drunk? Somebody answered yes? Okay. Have you felt one really understands how frustrating all this is? And then have you had a stroke or other neurological problem that affects your balance? Have you had numbness in your legs, in your feet? If you've answered to one or more, you have a balance problem, or maybe not. We'll come back to that. So this is you in synopsis. So if you see your different symptoms that you might have, we talk about this all over, wrong one, here it is. Really what I want to concentrate on is something called postural instability, which is balance. So one of the primary motor symptoms, again, is as a result of the inability to move is your balance problem. So it's a tendency that you're unstable when you're standing, unstable that when you're walking. That means your reflexes associated with Parkinson's may not be helpful. You're maintaining an upright position is more difficult. When you experience postural instability, you might fall backwards, especially if you're jostled. Right? Somebody might come hit you as you're walking and you are walking into a wall, you might fall over, not a good thing. The most disabling symptom is due to the increase of falls. And falls at an older age is not a good thing. It's one of the 4 primary symptoms of Parkinson's disease. So tremor is one, rigidity, your abnormal stiffness in the limb or any part of the body, bradykinesia, the gradual loss and slowing down of movement, especially spontaneous, and last but not least is our, so here it is. You started upright at some point and now you are sort of cockeyed as in the first one on the right or left. You're starting to lean over, and then person in the middle with that posture, don't want to go there. So that changes your center of gravity. If that changes your center of gravity, you're likely to pitch forward. Not a good thing. You're likely to pitch forward. Not a good thing. So again, postural instability is not related to a loss of dopamine, but is believed to be damage at other parts of the brain. All right? So one theory is that the damage of the noradrenergic neurons, or the nerve cells that produce the neurotransmitter norepinephrine, is really the cause. It affects your quality of life if your balance sucks. It also affects your mobility, right? You've often heard, if I fall and break a hip, not a good thing. So in this particular study, 489 patients admitted to the Department of Neurology, 60% of Parkinson's patients had a history of at least one fall over the previous 12 months. That's a lot, right? It's more than I care for you to have. Another analysis or another study talked about fall incidences. Even with the optimally medicated early stage Parkinson's, it's 40 to 70% of those folks have balance problems. So it's evident that balance dysfunction and related falls are fairly common. So risk for falls increases gradually as your disease progresses. So if you're in stage 1 and 2, not so much of a problem. As you start to go into 2 and 3 and 4 and 5, you're in trouble, okay? But if you can get that vigorous intervention, the key word is vigorous. So you can get up and move and be a lot more active, that will actually reduce your falls risk. And if you cared, a ton of research is out there to support all of this. So it's not as if I was pulling this from somewhere where the sun doesn't shine. Postural instability is better known as your poor balance, and coordination is in trouble. Your loss of reflexes, again, is the inability. So remember that balance has different strategies. You have one from the ankle, you have one from the hip, and you have a stepping strategy. So if you don't have those, your likelihood of losing your balance is much, much higher, or at least you can't stop it as you start losing your balance. So it can increase your risk of falls. It's one of the most vulnerable mechanisms of human function. It's also one of the most retrainable. So just because you have Parkinson's, yes, you have a balance problem, but those of you who don't have Parkinson's, your caregivers, you have a balance problem potentially as well. So you need to look out for each other, so to speak. So with practice, postural instability can improve, and some of the automatic balance reflexes can be regained. What am I saying there is that, remember that your automatic pilot has taken a permanent leave of absence. You no longer have anything that's automatic. If you don't think it, and what did Juliana say? Without intent, you're in trouble. So if you think it with intent and you can think the process through and you have enough dopamine on board, you can send that message from what you think to what you do in the motor cortex. And you should be good. That's the that's the thought piece of the puzzle. What about sit to stand? Is that automatic when you walk? Is that automatic? Yeah. No, not for you. However, balance, you can actually train for that to become a little bit more automatic, to worry that your autopilot is gone, okay? So to achieve greater balance, your brain must combine information from all the levels of the nervous system, as well as the musculoskeletal system. We'll talk a little bit more of that in a second. So the basal ganglia plays an important role in your balance, and I'll start tying things together as we go along. Your basal ganglia is also the part that's affected by Parkinson's. The neurodegeneration of that substantia nigra, pars compacta, big words, dopaminergic neurons, and the loss of the dopamine depress that nigrostriatal pathway, and motor activity that includes balance becomes impaired. So bottom line is you've lost some of that because of that loss. A lot of big words. So impact on the brain can also cause delays in the person's reaction time. Remember, we talk about bradykinesia, your slowness in movement. If you start to lose your balance backwards, you are going to be doing slow movement. Whereas I expect you, if you start to lose your balance with practice, you should go done, right? And that's what I expect you to be able to do. Remember that your postural riding reflexes, as your balance sways or your body sways off center, gets you into trouble. It might take you too long to get back to that center of gravity again. So what is balance? Balance diagnosis is fairly actually simple. And then what is treatment for it, or what's the rehab process? So let's take a look at the different pieces for balance. You have 3 pieces that we'll talk about. The first one we'll talk about is actually visual. Your eyes play a big part in keeping your balance. In fact, your eyes provide the most information to your brain about your balance. And I'm not talking about necessarily just vision alone. Can you see? If I do the eye test, are you 20/20? That's one part of the puzzle. I'm more interested in whether your brain perceives what you see. So what you see is not what you get. That's what we're going to improve, okay? Your second system is your vestibular system. This is your inner ear. This is your gyro. This is how you keep your balance with a structure that is in about the size of your little pinky, tip of your little pinky. Very small, but at the same time, very important. And the last but not least is your proprioceptive somatosensory piece of the puzzle. That's your legs. That's the feedback that's coming from your legs that might not be so strong. So if you look at your vision piece of the puzzle, it's again how you fix on a object as you look at it. Right? So one of the things you'll hear us say in the clinic is, can you see as you turn your head? What are you seeing? A lot of the times when you turn your head, you're not focusing, all right? So very quick for me. Turn your head to the right very quickly and back to center, and then tell me what you saw. Most of you were going, what? What did I see? I saw nothing. That's the problem. So every time you turn your head, you need to find something in your line of sight, which will help your brain understand where you are in space. Right? Remember, that's not just left and right. It's also up and it's also down. If you miss that crack in the pathway in front of you, guess where you're going to go? Right? So vision piece of the puzzle is important. This better not be you. There are two modes, and really all we... This better not be you. There are two modes, and really all we care about is this focal 8 inches from center. So about 30 degrees either side, and that's the most important part. When we talk about peripheral vision, that detects attitudes, that detects motion outside of where we need to really be focusing on. Is that important? Yes, it does, but it doesn't provide visual acuity, right? So, yeah. Your vestibular system reports your head movement to the brain. This is your vestibular ocular reflex, how your inner ear ties in to your eyes, ties into the brain. This helps keep your fixation on that target when you move your head, especially when you start to move your head quickly. Oh, wait, I forgot. You don't move quickly. Eventually, you're going to learn how to. It's important that you do it with intent. Turn your head like you mean it. Look like you mean it, and not go slow. So this is a very busy slide, unfortunately. I just wanted to point out to you what that system looks like, and that's this thing here. All right, that's your vestibular apparatus. So let me break it down a little bit more. If you see the canals on either side, and that snail-looking thing on that side is your puzzle. So sometimes your hearing goes south, like you flipped a switch, and that might affect your balance piece of the puzzle as well. So we'll ask you that question. When you move your head at any time, there's fluid in those canals. Your head, your brain perceives where you are in space. The one on the right will push, the one on the left is supposed to pull. But if the one on the right pulls and the one on the left pushes differently, you are unstable. You will have vertigo. So another question we'll ask, do you have any spinning? Is your world going around in circles, or do you feel like you're going around in circles? All right? So as you move your head, you push on something called, whoops, went to the start, and that's not, oh, yay. Thank you. So as you move your head and the fluid moves, it pushes on the cupula. That's your sense organ. Remember when we're talking about this structure, it is about yay big on either side of your head. So it's very small. We're made rather remarkably. And if you can imagine that little thing is keeping your balance, that's pretty amazing. So the last piece is your somatosensory piece, your proprioceptive piece. It tells you where you are in space. Okay? So, so that's your somatosensory system, so you understand where you are at any point in time. So all those three systems send information to your brain, your CNS, and that sends it out to a motor response to where you can actually walk, you can actually move, you can put your arm in the right position when you're putting on your jacket. All of those are necessary pieces to the puzzle. What happens during a conflict? So if one or more of the systems sends a message that conflicts with the others, problems occur. Remember the Tower of Babel, right? If all of you speak a different language, nobody understands each other. So the goal of therapy is to get those systems to understand each other. So imagine you are a passenger in a car and it's moving. As you're going down the highway, you're trying to read that, well, you're a passenger, remember that, not the driver reading a book. After a period of time, you feel carsick. Why is that? The carsickness is because your brain tells you two different things. Your eyes are telling you that you're still, but your vestibular apparatus, that those canals with fluid in them, tell you you're moving. And that conflict gets you into trouble. So those of you who are carsick, you're going, I can't fix that. And the answer is no, you can. All right? So that's another automatic response. This carsick reaction is really your balance problem. Right? So you might not feel carsick when you're walking, but it's certainly that imbalance or that inaccurate from one system to the other information that causes you to feel unsteady. And if you imagine this feels like every day of your life that you're not happy about it, you need to really fix it, right? So don't wait too long before you decide, I need to fix my balance problem because it's a huge issue. What are your risk factors? Things that you can change to help get your balance back. If you're taking 4 or more medications, okay. Lower body weakness. Your legs are not very strong. What about when you have problems walking with and balance while you're walking? Can you modify these? And the answer is yes. Obviously, you can lower your body strength or your leg strength by strengthening it. And don't tell me that you just move your legs and that counts as strengthening, by the way. That's not. You have to overload the muscles. And in order for you to overload the muscles, you have to do resistance bands. So you have to use weights. So walking in of itself, yes, it might help because you're carrying all that mass over your legs as you're walking, but not sufficiently. You can improve balance. Again, we talked about the 3 systems. Each of those systems are modifiable. Each of those systems you can change and become, quote unquote, automatic. Right? And then if you haven't already talked to your docs about your medications, if you're on 1,000 of them, please talk to them. Because a lot of medications have a side effect of what? Lightheadedness. Not so happy about the things in terms of balance. Right? Your vestibular apparatus is affected, and you'll see that in a second. So reducing that will be helpful. So 4 more, you're in trouble, potentially. So do you know where you are in space? Yes. And can I modify all of that? I would hope that I can put my head back. So taking a look at your stability. Stability is your balance issue. One of the things that we'll talk about as we go through treatment is definitely your motivation. What's your arousal level? How are you planning on paying attention to what you're doing on a day-to-day basis? Is your age a big deal? No, not necessarily. So I see balance patients anywhere from the teens, even right now I have one that's 12 years old. I guess that's a teen. The youngest one I just saw yesterday was 6 years old, all the way up to 96. So balance problems are not just a Parkinson's issue, all right? Development and refinement of your motor strategies, your ankle stepping strategy. For me, stick your foot out and pull your foot up. Past neutral or 90 degrees, can it come up? If it cannot, you have lost your ankle balance strategy. And if you lose your ankle balance strategy, if I start losing my balance backwards, all I have to do is pull my toes up. If you don't have that range of motion, you can't pull yourself back to center. One strategy lost, all right? How about your hips? Are they weak? If they're weak, you need to strengthen them because that's your second balance strategy. How about walking backwards? When was the last time you walked backwards? hopefully this morning when you went to the restroom. But if you're not doing that and not doing with intent, and you're taking that nice ginger step and trying to step backwards and lose your balance, that needs to get corrected. All right. So again, we'll talk about that. Your height, weight, and strength. Yeah, if you're overweight, you're a little bit in trouble. Why? Because that belly in front pulls you forward. Your center of gravity is now shifted. So not necessarily a good thing, but fixable, sort of. And the environment. How many of you have throw rugs on the floor? Those small little things you like to step on. Guess where they need to go? To somebody else's house. And then how do we put all those systems together in organizing your sensory components, your vestibular system, your visual system, and your vestibular apparatus? How do I get that back? I left the last, which is the amount of practice. You hear me say this a lot, and those of you who see me, you know that I don't care for you to do one repetition. I care for you to do tens and hundreds of repetitions. The more repetitions you do, the faster your system corrects. On average, your system learns with repetition. So let's say you have a bad habit of walking with a shuffling walk. It only takes you 300 steps and it's stuck. It takes you 3,000 steps to undo it, right? So some of your balance pieces requires a lot of repetitions throughout the day. So 50, 60 repetitions a day. And you're going, I don't have the time. Yes, you do, if you want your balance back. For a couple of reasons, right? This one doesn't have any balance anymore because it's all in. But also, what came first? Was it the cart or was it the horse? Well, in this case, was it the cart or was it the horse? Well, in this case, it's the So I want to introduce you to another piece of the puzzle that maybe some of you have, and that's vertigo. Vertigo is when the room is spinning, or you feel like you're spinning. This is your vestibular apparatus. The semicircular canals, or those central projections, or both, send the message to your brain as to where you are in space. So if one is causing you to have spinning, by default, you're going to have imbalance. When you roll over in bed and you have the spinning and you're going, okay, not so happy, or when you bend over to put your shoes on, you have the spinning, we're in trouble there too. How about when you try to get something off that top shelf and you have vertigo? All of that tells me your vestibular apparatus is not working, so we're in trouble there. So if your body or the room tilts, your autolytic system is out to lunch. Oscillopsia is another one that you have. Maybe we talked about vestibular ocular reflex, and that's your eye connection between your brain and your vestibular apparatus. So if there's a mismatch there when you turn your head quickly, by default that system is not working, and that's called oscillopsia. So if you imagine the world doing this whenever you are looking around, not a happy circumstance, but hopefully you don't have that. We talked about medications that are vestibular suppressive. In other words, they prevent your inner ear from learning. So if you are by default taking some medications prescribed by your physician to help you with your balance or your dizziness, might want to talk to them about this. So meclizine, antivertebronine, Ativan, lorazepam, are these words semi-familiar to some folks? If they are, please talk to your docs about it, because this is not necessarily a good thing. Unless you are spinning out of control, it will help you slow down that spinning and become a little bit more comfortable, or at least manage it. But taking it long-term will actually prevent that system from learning. And guess what? Your balance is in trouble. If you have a downward spiral, what happens with your balance gets you more impaired and subsequently loss of independence. And I'm sure that's not what you want. So early intervention, if you recognize that you're off balance, please get help. And the sooner you can do that, the better off you are. So any time you have that issue, please get help. Cannot say that enough. Can you reverse it? And the answer is yes. I don't care whether you have Parkinson's or otherwise. It can be reversed. It can be corrected. And how do we do that? Balance retraining. We do strengthening exercises, not just walking and not just moving your arms or legs. We really push hard to get those stronger using resistance, which is important. Endurance training. If you're walking 10 feet, is that good enough? My answer, no. You'll see why in a little bit. And then hearing correction. If your hearing's in trouble, that's another piece of the puzzle you need to look at, because your hearing tells you where you are in space, or tells you when you come to a red light and the fire engine comes around the corner and you missed it because you didn't hear it. Well, you draw that picture. And then getting back into the system again, getting back into being able to get around the home, getting around the community, something we want to take a look at. So in combination, we have the right diagnostic piece and the right equipment, the right rehab process, the right staff. Knowing how to put all this together makes a big difference in putting together and correcting that puzzle. So we can correct the eye vision piece of the puzzle. Can you follow that? Did you miss that? All that. If you missed it, your eyes are not moving fast enough, and therefore can create a balance problem. Ankle sways, and a whole lot more. So we'll walk through some of these very quickly. All the other limitations we need to address that might impact balance, right? So pain. If you have pain, the body ignores everything else. Pain is, I'm in trouble. Danger, danger, Will Robinson. A range of motion in the neck is not good, therefore you need. And in the ankle, we talked about that. So if your ankle cannot come up, we're in trouble. If you cannot turn your head, we're in trouble. Muscle strength, upper back. How many of you are doing this? Not good. We need that muscle strength to pull you back at the center of gravity where it's supposed to be. And that center of gravity is literally about 2 inches, or rather an inch, in front of your tailbone. So if you remember that cart and the horse, if your center of gravity is where all that weight was in front, you tend to feel like you're falling forward, right? And then incontinence. Why is that important? You're not getting rest at night. I'm waking up 3,000 times. If you're fatigued, you are going to be tired. And when you're tired, your balance is in trouble. And obviously many more. So how often should we do exercises? Posture, we need to correct daily. Range of motion, we need to go through and get that range of motion back. If you have pain, we're going to address it. Don't work through pain. That's not a good thing. All right? Strengthening, 2 to 3 times a week. Balance, daily. Cardiovascular, we'll talk about this in a second because that's the most important, 5 to 7 days a week. Any assisted device needed. If you cannot walk stably, you probably need a walker or a cane or something similar, a trekking pole. All right, this is my plea to you right now. This is a long slide. No medications have been proven to slow down the progression of Parkinson's disease. Of concern of long-standing Parkinson's disease is cognitive decline, as well as motor symptoms unresponsive to dopamine replacement therapy. Not fully recognized as a substantial accumulating evidence that long-term aerobic exercise may attenuate Parkinson's progression. Which means what? If you have an aerobic capacity, you can actually slow down the Parkinson's process. How cool is that? All right? So that cardiovascular improvement is something you want to push pretty well. There's plenty of literature to support that aerobic fitness is the key to this entire piece of the puzzle. All right, so what is aerobic fitness, otherwise known as cardio? Involves continuous movements, large muscles, rhythmic manner, increases your heart rate. That's the key, right? So remember what your target heart rate should be, and then to maintain that performance fitness. So there are tons of things you can do. If you're saying, I can't do this, I can't do that, there are a ton of ways to get your aerobic fitness in. So why is this important? It's mediated by the neuroregeneration of the dopaminergic nigrostriatal system. What does that mean? You can actually cause your brain to produce more dopamine by having an aerobic exercise program. So it's one of the nice pieces of the puzzle. It actually, remember that if you're exercising, it actually produces or reduces that neurotoxic destruction, and so therefore improves. Okay? Studies have documented significant increase in brain-derived neurotrophic factors with exercise resulting in neuroplasticity, which means what? As I said, your brain can actually slow down the process of Parkinson's, right? And here's where I start tying things together for you. So low serum BDNF concentrations were significantly associated with reduced cognitive scores. So your cognition goes south when you don't have that exercise, right? Serum BDNF significantly increased with 1 month of treadmill training. It increased with 8 weeks of cycling. That's pretty cool, right? You can actually slow down your process of Parkinson's. You can actually cause your brain to be neuroregenerative and produce more dopamine. It also improves balance. So if you have more BDNF on site, therefore you can get that through treadmill exercise. Remember that you're not walking flat. A lot of times you want to push your heart rate up, so it might be that we have the incline going. I can't walk on a treadmill. There are toys out there. In particular, this particular toy is like it. Being in a harness, I can literally have you running today, right? I can have you walking at pace. Remember that with bradykinesia, everything slows down. My goal is to increase that speed for you. My goal is to get your brain to understand that nice, long, fast walking pace is where you want to be. What happens when you feel that you're off balance? What's your first thing that you do when you walk? Slow down. You're already slow. I'm going even slower. Not a good thing. Can you stand on one leg? Can you stand on one leg and write the alphabet with the opposite leg? No? If you can, we put you into that, never mind. But if you cannot do that, you cannot walk slow. Think of this. If your legs are off the ground more often, are you more unstable? The answer is yes. So walking faster is important. Eyes closed exercise. We're going to work the inner ear. Single leg stance. Can you stand on one leg? And, you're going, no, I can't. With time, you can. And with time, yes, you will be able to write the alphabet. And with time, you will be able to improve your balance that way. Visual exercises. We use, my favorite letter in the alphabet is the letter E, because we'll use that as a target. We'll force your eyes to learn how to do that again. Hip strengthening. All the planes of the hip, which is, again, your hip balance strategy. Ankle stretches. It's very simple stuff, if you noticed. It's just time consuming. But if you do it, you are guaranteed an outcome. Upper back posture. All of you that are slouching, this is you. Time to correct it. Here's the first one, a seated row. All right, doing a lat pull down. Doing something we fondly call doing your snow angels. Being push-up, working on push-ups. And when I say push-ups, you're not pushing up off the floor, pushing up off the wall to start with. And then stretches. To open up your chest wall so you're not slumped over all the time. There are other exercises to consider. Remember that Bruce right up front said this is not really good. We don't want to exercise. We do. Exercise is the most important piece of the puzzle, right? So massage can relieve your rigidity. So if you're not getting that, maybe that's the way to go. Meditation to relieve your anxiety. If you're anxious, you can potentially be off balance. Tai Chi. If you haven't tried Tai Chi, it's a fun thing. Remember that if you speed up Tai Chi, you can be the next Bruce Lee. Proper sleep. Like I said, if you don't get enough rest during the night, you're in trouble. So if you have restless legs, if you have that, I got to go to the restroom because my bladder's full, things are all fixable. You need to correct that so you can get good sleep. And then hobbies, friends, support groups for your emotional well-being. So that's essential. That's it. Thank you. Do we have time for questions, or do we want to hold it to later? 2 questions. It's called a cattle prod. No. You as a caregiver are the most important piece to that puzzle. You are the motivator. You are the person that will have to coax them into doing that activity. When he starts doing the exercise, he's going to feel a lot better, and that may be the other piece of the puzzle. So we just have to get it started, get him to understand that, let's go walk a little bit, let's see how we can do better. And by default, he's going to feel better and therefore maybe pay attention to continuing to do that activity. Yeah.
Are there some good videos out from exercise?
I'm very cautious about that because the internet is a wonderful place to go. It also is a wonderful place to get into trouble. There are tons of exercises out there, and not all of them are made equal. You definitely want to be assessed to make sure that you've got the right pieces in place so that we can put the right interventions and correct all of the above. So, one exercise for you might not be the same exercise for somebody else. So as we go through the evaluative process, we are very cognizant that each person is very different, right? You might have a knee problem, you might have a neck problem, you might not have either. So it's very catered to each person and individual based upon the evaluation. We're able to give you a path or a guideline of how to do what, when, and how much. More? No? That's it. I only get 2. All right, good enough. You can always come by later on. I'll be happy to answer any other questions you might have. Right. Good.
Thank you.
Cool.
Yeah, we'll do it. All right. Thank you very much, Keith. We'll take another 5-minute break before we get to our next speaker. We have a special award ceremony. So feel free to grab plenty of bagels out there as well. So take care.
Detach. There we go. Matt.
All right, I am here to introduce our next speaker. Our next speaker is Dr. Kevin Klos, a movement disorder specialist here in Tulsa, Oklahoma. A native Tulsan, he received his medical degree at the University of Oklahoma before finishing up his residency at the Mayo Clinic. He established the Movement Disorder Clinic of Oklahoma in 2008, and currently that's where he offers a variety of treatments to equip not only patients, but family members with the tools needed to fight this disease. Dr. Klos was very, very active in the research of better Parkinson's medications and ultimately a cure. He also has a personal connection to Parkinson's disease, and this experience is what drives his passion to help caregivers. He even recently released a book on this topic titled, "You Are a Better Parkinson's Caregiver Than You Think." And on a personal note, I will add that he's one of the kindest physicians I've come across. I think I speak for all of us when I say we are very, very lucky to have Dr. Klos here in Oklahoma. So Dr. Klos, the microphone is yours. Thank you.
Okay, can you hear me? Are we on? No? Okay, how about now? Yeah. Trying to get this.
Did you turn that switch on?
That probably would help. How about now? Hello? There we go. All right, I'm with you guys. Yay. All right, well, thanks for being here this morning. It's so great to be in person with you again. It's been several years. Unfortunately, because of the COVID situation last year, we couldn't get together in person, but I'm so glad to be back. I want to thank Matt and Bruce and Lisa and the Parkinson's Foundation for inviting me this year. I've been involved, I think, with this foundation since the very beginning when it first started here in Oklahoma. So it's been a real honor to work with such wonderful people and to be a part of these symposiums as many years as possible. And so Matt asked me to do this talk about 6 months ago. And I was thinking, gosh, what am I going to talk about? What's something new that I can bring to the group? And I wanted to give a research update, which I'm going to do today after this talk. So I have a really difficult position right now. You guys are tired of sitting in this room and you're hungry, you're ready for lunch. So I'm going to try to keep your attention. And so I have 2 talks. I have the first one and then a second one after a quick break will be a research update. So I'm going to tell you about some of the new clinical trials that were published at a recent meeting just a few weeks ago, as well as some of the clinical trials that we have going on in our clinic here in Oklahoma. But first, this first topic I wanted to address something that is important for our patients that come in, and most of the symptoms that we talk about in the clinic are what we call non-motor symptoms. So very rarely are we talking about tremor and stiffness and some of the cardinal motor symptoms. We certainly talk about those. But what really seems to bother patients and caregivers are these non-motor symptoms. So we're talking about cognitive challenges. We're talking about pain, trouble sleeping, mood changes, irritability. We're talking about sleep challenges, bowel and bladder control. There's a whole list of things that can happen with Parkinson's disease. And then this obviously can affect the family as well. So it's a major challenge. And as I've given these talks over the years, presenting new medications, I'm always disappointed that I don't have new drugs to talk about to address these non-motor symptoms. That's where we're really struggling in the pharmaceutical pipeline to find therapies that can help these non-motor symptoms, but yet they seem to be the most troubling for most of our patients. So what I did is I wanted to look at, well, what other strategies can we give patients and families to deal with some of these problems? And so what I'm going to give you today, I've never done this talk before, but it inspired me to write a book about it. So hopefully this will be coming out at the end of the year. And I put together what I call Parkinson's protocols. These are suggestions that you can take to managing day-to-day life with Parkinson's and helping a loved one as a caregiver with Parkinson's that have peer-reviewed medical literature backing to these protocols. So these are not just sort of suggestions that we pulled from the air. There's actual studies that have been done looking at these different protocols. And what's exciting about it is all of us can look at these protocols and implement them for ourselves. You don't have to just be a patient with Parkinson's. All of us, including myself, we all could benefit from some of these protocols. And so I want to share those with you today. I also want to thank the foundation for buying the first book that I published, You're a Better Parkinson's Disease Caregiver Than You Think. They gave out some free copies today, and I want to thank the foundation for making that possible for today. So the way I thought I would organize this is to break it into different parts of the day. So looking at a morning routine, looking at an afternoon routine, and then looking at an evening routine. And please understand that any of these protocols or suggestions are not protocols that you have to put in place or else everything's going to fall apart. They may not work for every single person. And these are protocols that you really should talk to your healthcare provider about before launching in, especially with some of the supplements that I'm going to talk about today. You really should talk to the doctors that you work with and make sure that these are safe for you or reasonable suggestions. Let's start with a morning protocol. So I wonder, as we reach the time in our life when we're retiring, how many of us have a regular wake-up time in the morning? Many of the patients that I talk to don't have a set wake-up time. In fact, they'll tell me that, I have nothing really to get up for in the morning, so I might sleep in till lunchtime, or it may vary from day to day. There's no set regular time. And I'm going to talk a little bit here in a moment about why that would be important to try to have a more regular wake-up time in the morning. It's become very interesting to us in the science world that the circadian rhythm, the biological clock that is set, is very important in regulating a lot of these non-motor symptoms. So getting good sleep at night, having good mood during the day, our wakefulness during the day, and our ability to sleep at night, all of that is sort of governed by this clock, and we have to pay attention to getting that set correctly. So I'm going to talk about the circadian rhythm here in just a minute. Now for patients, when you wake up first thing in the morning, the two things that are typically missing from overnight sleep, one is dopamine. So typically you've taken your doses of dopamine the day before. overnight when you were sleeping, it's worn off, and now you're in a low dopamine state. The other thing that we're missing is typically hydration. So we're sort of dehydrated through the night as we were sleeping, and now we need to get rehydrated. I talk to a lot of patients about this issue of low blood pressure in the morning. So some of our patients are having difficulty when they try to get out of bed in the morning. They're feeling very weak, they're feeling slow, lightheaded or dizzy, and it may not be obvious that it's a blood pressure problem. It may just feel like my Parkinson's symptoms are now strong first thing in the morning. I must just need my dopamine and then I'll feel better. So they take their dopamine and this feeling may not go away. They may still feel very tired and fatigued and weak and have trouble getting around and getting started. So for many of our patients, we find out that this has to do with low blood pressure. So a good strategy or protocol would be to check your standing blood pressure in the morning, typically first thing in the morning. But another good time to check it would be after breakfast, when now the digestive tract is trying to digest the breakfast and some of that blood is being pulled away from the main core system, and you may have even lower blood pressure after breakfast. We need that blood pressure in the standing position to be 90/60 or greater. If you check it sitting, your blood pressure may be 120/80, or if you go to the doctor's office, they'll check it sitting, and you'll think, oh, good, I have good blood pressure. 120/80, perfect. There's not a blood pressure problem that I need to worry about. But in reality, at home, when they stand, there's this drop that happens. And this is a relatively common feature or non-motor symptom of Parkinson's. So caregivers, one thing that you can do is help out your loved one by keeping a log for them. Good blood pressure cuff, you get a log like this one and make some recordings. You don't have to chart their blood pressures all through the day. We don't need to make this an obsessive compulsive thing, but we just need to kind of have an idea periodically how the morning standing blood pressure looks. And you can record those numbers and then bring it to the doctor and let us take a look to see if there's a treatment that might be necessary. Another blood pressure that you might consider checking periodically is the nighttime blood pressure. So if patients have this blood pressure fluctuation problem, they may also have what's called high blood pressure or supine hypertension going to sleep at night. And this can be very tricky to catch. It's very silent, so the patient's typically not going to feel different, but they lay down to go to sleep at night. Now the blood pressure shoots up to 200/100, and they have no idea that the blood pressure is that high, and it stays high like that all through the night until the very morning when it drops down low again like it was the day before. So you can have these extremes of high and low blood pressure in the same patient. And when pharmacists look at our prescriptions and say, what's wrong with Dr. Klos? He's giving this patient a blood pressure lowering drug, and then he's giving that same patient a blood pressure raising drug. Does he know what he's doing? Why pick one? But the reason we're doing that is we're often raising the morning blood pressure with a short-acting drug that will wear off. And then at night, if the blood pressure is high, we're bringing it back down. So we're trying to keep it level through the day and night. So this can be kind of a sneaky problem that may not be real obvious to the patient or to the family or even the doctor taking care of you. So keep that in mind as a protocol to consider. If you're seeing great blood pressures, you don't have to keep checking it every morning, but certainly if those symptoms are taking place, it's worth a check. So hydration is sort of the next key. I try to get about 16 to 32 ounces of water in the morning, first thing. Now, giving you a recommendation on how much water you should ingest throughout the day, as Keith said, you can go to the internet and find all kinds of information there about water and hydration needs. But I think this is an issue you should really talk to your doctor about, because we all have different challenges or variabilities with our kidney function, maybe with medications that we're taking. So if we just tell everybody, this is how much water you should drink every day, it's not going to be right for everybody. But it is important to hydrate, and I think in general, our patients are not drinking as much as they should, especially in the morning hours. So we try to get some water in first thing in the morning, get that blood pressure up a little bit. You can add a little bit of salt, maybe a quarter of a teaspoon of salt into the water. Some people even take salt tablets. Salt, magnesium, potassium, these are all important minerals for brain function and brain health. So we all need these minerals to come in along with our hydration. Okay, so now the dopamine issue that we talked about, our patients are sometimes struggling first thing in the morning to get going. And there's a phenomena that we call akinesia, where some patients first thing in the morning just cannot move. Their body is somewhat frozen until the first dose of dopamine kicks in. And if you're taking pills of dopamine, you might find that it takes an hour before it starts to work. So do you just stay in bed for an hour waiting for it to kick in, or what do you do? Well, if you need to get up and get going a little bit faster, we do have some rescue therapies now that you can talk to your doctor about. One, this is the oldest one, is the Apokyn pen. This is a subcutaneous self-injection. The dose is dialed in, and you just administer this up right under the skin, and you achieve a rapid on response from this medication. A similar option would be to take that same drug, which is now on the market by the name of Kinmobi. This comes on a dissolvable strip that can be placed under the tongue, and it gives a rapid absorption of a dopamine stimulating compound that's exactly the same as what's in the pen. And patients find this one to be easier to take than self-injections, of course. Another treatment is Inbrija. This is the inhaler that gives a pure dopamine delivery to the lungs with quick absorption and rapid turning on with the dopamine response. Now, many of our patients have said, well, gosh, these are several choices. What do you think? How do they work, or how do they differ? And I just wanted to point this out. This is kind of a busy slide here, but this is really trying to compare these rapid rescue therapies that are on the market now. On your left, you'll see the inhaled levodopa. If you look at the trials, it generally takes on average about 30 minutes for the inhaled dopamine to take effect on average. And we found about a 4-point improvement on a motor scale that we use called the UPDRS. Contrast that in the middle with the sublingual apomorphine, Kinmobi, that goes under the tongue. Similar time to onset, 30 minutes. A little bit stronger response in their studies of about 7-point improvement in the motor scale. And then on the far right, on your side, you see the subcutaneous injection of apomorphine generally takes about 20 minutes, so it's a little bit faster, and gives the highest improvement of the three of about 8 points improvement in motor scores. But they're all, giving you a pretty similar rescue and improvement within a 20 to 30 minute time window. Now, another option, this is one of our protocols, is to use a protocol called liquid Cinemet. So if you're taking carbidopa levodopa, the brand name is Cinemet, those yellow tablets can be dissolved in a small cup of water. I would recommend tonic water because the tonic itself sort of helps absorption. It gets it through the stomach faster, and it gets the drug absorbed a little bit faster than just plain water, if you can tolerate tonic water. But you don't need a huge volume, just a small volume, and you're giving the same dose that you normally would take in the morning. This little recipe of liquid Cinemet will give you the on response typically in 10 minutes or less. So it's probably the quickest of the options. All of these rescue options will typically only last about an hour or two. So you're not going to be able to start the rest of your day just with this one treatment and think you can bypass your normal medications in the morning. You still want to get your regular routine medications in. This is just an option you might consider to get you started, to get the day going and to get out of bed a little bit easier. So I just wanted to share that with you. Now, I promise not to talk about medications the whole time, so we're gonna switch to caffeine. And we do have some clinical trials looking at caffeine as possibly neuroprotective in Parkinson's. We don't have that answer just yet, so don't run out and buy extra coffee today just yet. But what I'd like to suggest with caffeine is that when we wake up in the morning, there's a chemical in the brain called adenosine. Adenosine is at its lowest in the morning, so that kind of allows us to wake up, to be alert, and to start our day. But as the day is going on, adenosine is building up, and as it builds up, we're getting sleepier and sleepier, like some of you here in the room right now. Somebody brought a pillow. I'm glad they did that because I want you to be comfortable if you fall asleep. But if we rush right away, first thing in the morning, we grab our first cup of coffee immediately, caffeine blocks those receptors where adenosine binds in the brain. So that keeps us more awake and alert. That's fine. But when the caffeine runs out shortly after lunch, we have the crash. That's when patients and all of us tend to sort of feel lethargic and tired and feel like we need to sleep in the afternoon. So what I would like to encourage is this protocol of delaying caffeine by 90 to 120 minutes after you wake up. So give it a few hours if you can. If you can't get along with your family because you haven't had the coffee yet, just go ahead and take it. But if you can get along, try to delay it, because what you'll find is that caffeine will still be working for you in the afternoon. You'll have more alertness, you have more energy as well. And I know some of you are thinking, well, I can drink coffee first thing in the morning. I'll just drink more coffee in the afternoon. Why delay it? Well, we know that the body typically metabolizes about 2 cups of caffeine a day. So more than that, if you're one of those people that's emptying the whole pot of coffee throughout the day, I know my dad's guilty of that. He admits his caffeine addiction. What you're going to find is that caffeine builds up. It's hard for the body to metabolize, and we can become irritable. Not that he's irritable, but you can become irritable. You can have more tremor as a patient. And so there's some negative, you can be even more anxious throughout the day with that extra caffeine. So by limiting the caffeine and delaying it, I think we can find some help there to consider as well. Okay, now this is probably one of the most important protocols I want to share for the morning. And I think this has been really hard for patients and caregivers to achieve, is to get light exposure in the morning. I think we're all so busy. It's hard to get outside. We're bombarded with things on email and on our phones and computers, and then we're running to different things. It's really hard, I think, to get outside. And as I've been talking to patients over the last few months about this, how many of you go outside in the morning and get light? And almost no one says, oh yeah, I do that every morning. Do you have to do it every morning? No. You can miss a day or two here and there, but it's the consistent exposure to light. Now, what I'm not telling you to do is to go outside in the morning and stare right at the sun and burn the retina in the eye. You don't want to do that. I don't want you staring at the sun. Even on a cloudy day, though, you're going to get plenty of sunlight coming in indirectly into the eye. And if you think, well, I'll just sit by the window, there's light coming in through the window, I don't need to go outside. Well, it will take 50 times longer to get the same light exposure if you sit inside and get it through the window, as opposed to being outside directly into that sun. So we want to get about 10 to 30 minutes of light exposure every morning. Again, not staring at it directly and not wearing sunglasses, but getting light indirectly in. We have cells in our brain called the melanopsin intrinsically photosensitive ganglion cells. These cells take in the light and they tell the place in the brain called the suprachiasmatic nucleus, that's the clock of our brain. It tells the clock, okay, we're setting the clock now. So you're telling the brain it's time for us to wake up, and in 12 to 14 hours from now, you're going to release all the melatonin to prepare me to go to sleep. Okay? So you're creating this circadian rhythm. You want to try to get this light exposure before 10 a.m., if at all possible. And getting light throughout the day is perfectly great too. That's not going to hurt. You're not going to be up all night because, I went outside 3 times today and got all that bright light, I'll never sleep again. But here's the other reason for it. We're trying to set this cortisol pulse that happens naturally. We all naturally want to get a cortisol hormone pulse once every 24 hours. And ideally, we want it to look like this. We want to see the peak, the pulse, in the morning, because that wakes us up, it makes us alert, makes us ready to learn, ready to remember things. It gets us started for the day, but then we want it to come down so that at nighttime it's low and we can fall asleep. We also want this cortisol to peak so that it's not high all throughout the day. And the reason for that is if our cortisol levels are chronically elevated throughout the day, we are going to have chronic stress, more anxiety, more trouble with mood, and in turn, more trouble sleeping. So we want to get this cortisol pulse so that we can time our sleep-wake cycles appropriately, and we can reduce chronic stress. So some of you might have a loved one in a nursing facility or independent living or assisted living, and the routine there may not be that they can get outdoors. Well, that's something I'm hoping to work with some of our local institutions, and I'm encouraging maybe all of you to work with them as well. Is there a protocol that they could consider for our patients to where they maybe take them outside sometime in the morning and get some light exposure and set those circadian rhythms correctly? When we're inside just with artificial lights all day long and sometimes all night long, our rhythm is off. We're not sleeping well at night. We're not staying awake during the day. It's all fragmented and a mess. I'm going to try to get this to play. So the other piece of the morning puzzle is we want to get outside and do something called optic flow. So taking a nice walk outside achieves 2 things. One, you get the light exposure that I'm talking about. But it turns out as you're walking, and this is not your exercise for the day, this doesn't count. This is just getting outdoors and walking for a little bit. It can be 10 minutes, it can be an hour or less. But the flow of motion that your eyes are seeing, and your eyes are moving from side to side to look at the surroundings. So even if you're not able to walk, you could be in a wheelchair being pushed, your eyes are still achieving the same optic flow. And if you can't get outside, you can do this indoors. Just walk up and down the hallways. This optic flow is telling the brain in a place called the amygdala to decrease the firing activity in that location. And what that does is it reduces anxiety and stress. It calms the brain for the day. So this little activity of going out and getting a walk early in the morning, or just getting outside and having optic flow, seems to be very beneficial for our health. And that's something that we all can do. If you want to learn more about the circadian rhythm, and in the book I talk more about the morning diet. I just don't have time today to discuss all of that. Things like time-restricted feeding, intermittent fasting, some protocols on protein versus carbohydrate loads in the morning. But there's also lots of great information in this book called The Circadian Code. Dr. Panda from Stanford has done a lot of research on the circadian rhythm and how this helps all of us. This is not just for Parkinson's, this is in general something that we can all benefit from. So in summary, for the morning, we think about our wake-up time. Wake-up time is important because we've got to get that light exposure, we've got to get optic flow going, and we're setting our biological clock. We're telling it when the cortisol peak is going to happen. We're setting up our day for more alertness, more energy, and less anxiety. And as a caregiver, that's also an important feature for your day to kind of reduce stress and anxiety as well. Okay, now I'm going to shift to the afternoon, and I want to talk about a patient that came to me not too long ago, and he said, I'm doing great with my medication. It's working all day long. I have great consistency, except for this 2-hour window right after lunch where I seem to just fall apart. Everything stops working correctly, and I feel like my medicine's not working. But then 2 hours later, everything starts working again the rest of the day. So why am I having this gap right after lunch, shortly after that? Why is this happening? And we talked about different things, and we learned that in the morning, he was not eating breakfast. So he was having his coffee and a little bit of water, but not ingesting protein. But at lunch, that was the one meal of the day. So he was eating all of his protein, carbohydrates, loading up the lunch. That was the one meal of the day. And then at night, may have just a little snack, but not a lot of protein. So protein, we know, can affect the dopamine levels, and it can cause the dopamine level that's in the brain in this therapeutic window, it can cause it to fall. And so he was loading in all that protein. And so what I'm encouraging patients to do that are on dopamine is to not give up protein. And you'll read that a lot on the internet. Go to a low protein diet. Just try to eliminate that from your diet so it doesn't interfere with your medication. But that's, I think, the wrong thing to do. We will have muscle wasting, we'll have weakness, we'll have a lot of problems in the later stages of Parkinson's if we don't have good muscle strength, and the protein is paramount to keeping our muscles strong. So what I encouraged him to do is look at some of the foods that he's eating. For instance, a fillet of salmon here has 80 grams of protein. I'm going to make you guys hungry. I can see the saliva already happening. A burger might have 30 to 40 grams of protein. A protein bar can have 20 grams of protein. And so we need to kind of pay attention to how much protein we're ingesting at meals and snacks. And it's generally pretty easy to look on labels and to get an idea. We're not talking about the weight of the food. We're talking about grams of protein in the food. And you can look up all the different protein counts on different food items. We have this in the book as well, but it's a way to adjust your dopamine according to the protein intake. So what I did for this gentleman, instead of telling him, don't eat just that one meal, eat 7 times a day instead, or take all the protein out, just have a cinnamon roll or something for lunch. Instead, what I told him is keep eating the protein, but we're going to change the dose of the carbidopa-levodopa that falls at the lunchtime. We're going to overcome the protein with a stronger dose of medication to buffer the protein effect. So it's similar to diabetes, where depending on how many carbs you're eating, you have to match the insulin according to how much sugar and carbohydrates you're eating. So we have to do the same thing in Parkinson's with protein. We have to match. And that's something you have to work with your healthcare provider on. How much do I increase? Which medication do I increase? How do I adjust for my protein intake? But that's something that you can put in place and find a very smooth, more controllable day. Okay, now, this is just a term I put together called the Parkinson's pause. I think patients do best if they have a break in the afternoon. This could be in the form of a nap. It could be meditation. It could be hypnosis protocols, yoga. But there needs to be, I think, a break to let the brain go into a slower wave, more relaxed state. This helps reduce anxiety levels. This actually helps neuroplasticity. During these breaks, we find that the brain is rewiring and making new connections for learning, for memory, and also for sensory motor learning. So if you went to exercise with Keith that morning and did his exercises, that rest period is actually helping the brain make those new connections to teach the brain how to balance differently than it was before. So a lot of athletes are doing this. They'll have a training session where they're doing their athletic activities, and then they close their eyes and they take about a 2 to 5 minute pause and just let the brain relax for a minute, and it helps put those connections together so that they can have better performance. So if you're taking a nap in the afternoon, I would recommend that you take less than a 90-minute nap. And I think there's people who just can't take a nap. There's people who are not nappers. If they try to nap, they're not going to sleep at night. And then there's others that really benefit from a short nap in the afternoon. They can sleep fine in the evening as well. But if you're not a nap person, then you can think about some other protocols. This is a website called Reverie. This is hypnosis, but it's not the type of hypnosis like you see on the stage where they're trying to do something that they're not normally going to do. This was a program developed from Stanford and Harvard and other institutions, psychiatrists that put together protocols that help you get into that deeper relaxation stage, not sleep, but just into a calmer state, and helps the brain kind of refocus on different tasks. And they have programs if you're trying to help with sleep, if you're trying to help with pain, anxiety, mood programs. It's really an interesting program that you might check out. And if you're having trouble sleeping at night and wake up in the middle of the night, this is a good place to consider. You can pull out one of these hypnosis protocols, and some of them are just a minute long, some are 10 minutes long, and it kind of helps relax the brain and get you back to a sleep stage. I want to teach you something called the physiologic sigh. So research has been done on breathing and how important breathing is to the nervous system. There are breathing protocols that you can use to help make you more alert, make you withstand difficult conditions like really cold temperatures and so forth. But this physiologic sigh, it engages the parasympathetic nervous system that helps us get calm and relaxed. And this is a technique that you can use as a caregiver if things are getting really stressful and intense and you just feel like, I need a break. You can try the physiologic sigh as a way to calm yourself and re-engage. Patients can also do this when they're feeling overwhelmed and stressed. So I'm going to teach it to you. The physiologic sigh is a double inhale. So you're going to take a deep breath in through the nose. And right when you think you've got all the air in that you think you can breathe in, you're going to take a quick second inhale. So it's a double inhale. It looks like this. So it's sort of 2 inhales. And then the exhale, preferably through the mouth, is longer than the inhale. So it's a shorter inhale. So try that as we do this together. And you don't want to hyperventilate doing this. You don't want to get yourself so relaxed that you fall asleep. So I won't have you do it more times. I don't want to lose you. But maybe 3 to 5 repetitions of that would be all that you need. So you don't have to spend minutes or hours doing this. But this engages the parasympathetic system very directly, and there's good science to show how this works. And it can calm people down. My daughter is playing basketball right now in St. Louis, and she gets real nervous, and I told her, do the physiologic sigh. Do it right before you get out there and shoot those free throws. So athletes are using these as well to try to calm and keep their muscles and body relaxed. So it's a good way to treat some of that stress and anxiety that we have. I also want to mention a supplement called ashwagandha. This is a herb used in traditional medicine in India. I'm not a supplement pusher by any means, but there is now 6 studies, peer-reviewed studies in the literature that have shown that this particular product can help lower stress levels, and it does that by reducing some of that cortisol that might creep up from stress in the afternoons. So you don't have to use this every day. Some people just take it out on really stressful days and take one dose. It's not something that has to be routinely used. But there are also 5 studies that showed not only a reduction in stress, but also better cognitive performance and less fatigue. And lots of our patients are reporting fatigue problems. There was also a mild benefit for depression. So you can talk to your doctor about this supplement if this is something that would be right for you, but it doesn't require a prescription. And then exercise. Now, exercise does not have to be done in the afternoons. You can certainly do exercise in the morning or when it's right for you. But I want to stress, like Keith mentioned, and I won't go through all the details since he did a nice job of that, but there are lots of good studies showing not just the cardiovascular benefits and the muscle benefits, but also the benefits for neurodegenerative illness like Parkinson's. So there are studies that have used MRI to measure parts of the brain before and after an exercise protocol, and they did this about a year apart. And they actually saw an enlargement, an increase in volume in a place called the hippocampus, which is important for memory and for learning. So it turns out that these exercise, these aerobic conditioning programs, even just a 6-month program, can change the brain volume and induce this neurogenesis. And this has been seen in healthy people as well as in patients with Alzheimer's disease. So it works for anyone really. And I want to mention another study that was published that showed if you simply walk a mile a day, it reduces your risk of dementia by 50%. So lots of incredible studies that we were putting in this book that really try to sell the idea that exercise is so critical for all of us, not just Parkinson's patients. What's the minimum that we have to do? Not that that's what you should strive for, is the minimum. You know, I always tell my kids, don't just do the minimum, go the extra step. But the exercise minimum to maintain muscle is that we need to do a minimum of 5 sets of exercise per muscle per week, just to maintain. So if you're not doing any strength exercises at all, then just with aging, we're losing muscle bulk and muscle strength. So you can do those 5 sets in one session once a week, or you can do 2 sets 2 or 3 times a week and get the same benefits. The more you get, the better chance you have of actually growing muscle and building muscle. So we like to see our patients doing at least 2 to 3 strength building sessions a week, as Keith mentioned, but not just our patients, all of us should be doing that. That's some type of resistance exercise, whether you're using machines, weight machines, or dumbbells at home, or bands, something that is causing resistance to the muscle movement. And then 2 to 3 endurance training sessions a week. That's typically at least 12 minutes of cardiovascular, increasing the heart rate sessions per week. And you really shouldn't spend more than an hour typically exercising, because if you go past an hour, those cortisol levels start to rise, and it causes more stress and potentially injury to the muscles. So we want our patients to be careful about over-exercising as well. Okay, we're getting to the evening now. And I'm going to go through this quickly because, again, it's in the book, but nutrients for brain health. These are not just for Parkinson's, this is for brain health. There's a number of supplements that you can get naturally through the food, or if you're not getting that kind of diet, you can supplement. And again, check with your doctors before you start implementing a bunch of supplements. I want to point out omega-3 fatty acids. This one's really clear. There's so many good studies now that show the improvement in mood, cognitive performance, and sense of well-being with the omega-3 fatty acids. We're probably not getting enough in most of our supplements that you might buy. We're recommending at least 1 to 2 grams of omega-3 fatty acids. if you're eating tons of seafood, if you're eating salmon and caviar, I'm not eating caviar, but if you're eating caviar, you'll get lots of omega-3 fatty acids, but also chia seeds, walnuts, sweet beans. There's lots of sources for omega-3 fatty acids, but most of our diets, I think, are coming up short. And so you might consider this. Now, why is this important? The omega-3 fatty acids in some studies have shown similar benefits in treating depression as our antidepressant prescription drugs. And if you're already taking an antidepressant prescription drug, you might be able to lower the dose if you add omega-3 fatty acids so that you have less side effects from the antidepressant. So that's something to consider. Choline is another product, about 1 to 2 grams of this one as well, because it's a precursor to acetylcholine, the neuromodulator that helps us remember things and learn. It's an important cognitive neuromodulator. We manipulate acetylcholine when we're treating Alzheimer's disease. So this is an important supplement. We're getting a pretty good amount of this, I think, in our diet, especially if you're eating eggs and some of the food sources there. But if you want to supplement that, you might consider extra choline. Phosphatidylserine has some milder evidence in the literature, but there are some studies showing better cognitive performance and slowing of cognitive decline, which we're all certainly concerned about. Alpha GPC is another one that you might consider. This is one that you really have to supplement. This can help athletes with muscle power and performance, but it can also help with cognitive performance. And in a study that looked at Alzheimer's disease patients taking alpha GPC, they showed slower cognitive decline with this supplement used. Creatine, there's perhaps some controversy on this one on the internet, but we know creatine can help with muscle strength and power, but it can also help cognitively. It can also help with our mood and motivation. And perhaps combining it with coenzyme Q10 may be a benefit for some individuals as well. There was a Parkinson study that looked at creatine, and they found a 50% improvement in the motor scores after 1 year of supplementing creatine. So creatine's been a popular supplement in the Parkinson's disease trial process, so keep an eye on that as well. I like to call blueberries brain berries because they're so good and rich in these anthocyanins that are important for cognitive performance. And we can take this as a supplement, 400 to 600 milligrams a day, or 1 to 2 cups of berries a day. You can get this in blueberries, blackberries, dark currants, and so forth. And finally, there's some literature on fermented foods, 1 to 2 servings at least a day. So many of us are looking at probiotics. We're trying to find ways to help with constipation, and we're thinking maybe better gut microflora in the digestive tract might help the immune system and therefore might help Parkinson's patients. Well, fermented foods seem to be one of the best ways to give a healthy microbiome to our digestive tract. And this is probably, now the new study is showing probably better results than taking a probiotic. It improves our immune system, but also we get better sleep, reduction in anxiety, and cognitive performance. So that's sort of the more technical stuff I wanted to share. This is a sunset here in Tulsa. So we talked about the light in the morning. So the second piece of the puzzle is getting some light exposure in the evening, because the light exposure in the evening continues to tell the biological clock that we are getting near the end, and it's time for the melatonin to start kicking in to help us with sleep. So if you can get out there and see a little bit of a sunset for 10 minutes or so, this will help optimize sleep. I'm half Hungarian. This is a picture of a bathhouse in Budapest, Hungary. These bathhouses have different pools of different temperature waters, and it seems that we can optimize our sleep performance by maybe taking a hot shower or getting into a sauna before bedtime. And it's not so much the hot temperature, it's the cooling of the body after you get out of the hot shower or the sauna that seems to help induce our ability to fall asleep. We need to be careful about light exposure after 10 o'clock. So from 10 p.m. to 4 a.m., we want to minimize light exposure. If we have bright lights on in the home, if we're looking at computer screens or our phones, that's making it really difficult for the brain to understand that this is a sleep time, not a wakeful time. So if you do wake up in the night, low level light is good. We don't want people falling, trying to get to the restroom. So if it's in the lower half of your visual field, that seems to have less effect. So dim lights in the hallways or in the room below the lower half can be helpful. But even light just coming in, through a clock or through the shades there can affect your sleep. So wearing a sleep mask might be something worth considering. A cool temperature in the room can be helpful for many. And again, not everybody has the same needs, but this is an ice hotel in Canada. Probably won't visit that one, but it's a way to cool the room to help with temperature regulation overnight. And there are some sleep supplements that one might consider. Many of you are taking melatonin. There's a controlled release melatonin that can be helpful. This might help those that are falling asleep fine, but then waking up and having trouble falling back asleep. The CR may be advantageous. Magnesium threonate at these doses has been shown to reduce GABA activity, which can help sort of shut the brain down and help it quiet down and get to sleep, especially if you tend to have a lot of racing thoughts and can't get your mind to calm down at the end of the day. This is one that can help you fall asleep. Apigenin is another one. This is a compound that can help reduce anxiety and help relax the brain. And finally, theanine is another one that can help calm and help people fall asleep. So you'll often find in the supplement section these products that have both melatonin and theanine combined to help with sleep. Okay, now why is sleep so important? And I think this is something that we really have to focus on in the Parkinson's clinic. During sleep, we have this system in our brain called the glymphatic system, and it basically gets rid of the toxins that have built up through the day and kind of cleanses the brain. Well, this glymphatic system only wakes up to do its job when we're sleeping. If we're awake, it doesn't do much of anything. So during sleep, we're getting rid of those pathological toxins like the alpha-synuclein, the Lewy bodies in Parkinson's disease, or in Alzheimer's disease, some of those pathological proteins. And the sleep process is really helping us clear those. So studies are looking at people who have low levels of sleep, that have poor sleep efficiency, and how fast the disease is progressing. So we really need to help, I think, our patients and our families achieve sleep in a better way if we're going to battle this condition. Okay, and then finally, one of the best ways for long-term stress is social connection. We have to make connections with our family and friends and others. These type of meetings, support groups are also wonderful ways for us to stay connected with each other. And this helps to reduce a inflammatory system in our body called tachykinin, which if that builds up, it can cause people to be more irritable, paranoid, have more fears and more negative feelings. But when we're socially connected, when we're releasing serotonin because we're making those connections, it suppresses tachykinin and helps us feel better. And I think as caregivers, we're really finding our deepest happiness, our best worth in life by serving others, by helping others instead of ourselves. This is a quote from Mother Teresa. So I know I covered a lot. I couldn't give you all the protocols in this book that's hopefully going to be coming out later this year. If you'd like to be on an email list to find out when that's coming out exactly, come to my table down there in the corner. You can put your name and email or contact information in that little box so that we can get that information out to you. It's not ready for pre-order just yet. For HIPAA compliance, we're trying to have that privacy where you can just put it in the box. And I was told, Bruce, that I won the award again this year for the worst decorated table of the group. So I can't compete with all these companies over here, but I tried to give you guys some information. So I'm going to stop there so that our next talk can be about research, and I'll let Bruce take us through a little break here. So thank you for your attention on that.
Okay, so
You might have to use
Dr. Klos is going to take, we're going to recalibrate just a bit, and then he has a short research update. So I realize if you need to go into other appointments, that's okay, but we're gonna do just a little bit extra here on a research update of the current status of all that. And while he's getting that set up, I'm going to take you through a few exercises. So plenty of bagels out there if you need to get up and get something here for the next few minutes, but follow along in your chair. Just march with me. Swing those arms. Don't hit anybody beside you or behind you. All right, and now we're going to introduce a little bit of complexity here, okay? So we're going to get a little dancey, but we're just still going to sit down. All right, so we're going to kind of bounce it off the hill and raise the other arm. Some of you, it look very much like John Travolta. Matter of fact, let's try that. Same foot, same arm. Let's do the other one. Now you're just feeling silly. This is not candid camera, don't worry. All right, that's good. Now let's try a little complexity. Just tell me when you're ready. Write your name in cursive with your finger. Now do it backwards.
You ready?
Yeah. Oh, let's try your weak.
You ready?
Yeah. Oh, let's try your weak hand. It didn't matter how you did it. Good job. All right. All right.
Okay. Thank you, Bruce. Thank you. And we definitely understand if you're just oversaturated and you've had enough. So we thank you for all your patience this morning and sticking through all these great presentations today. And we thank the presenters as well. But I wanted to give you a clinical trial update because, as you know, this is a big part of my practice. It's something that I do more and more so, it seems like each month. So I want to tell you about some of the exciting news we've learned and tell you what trials we have ongoing as well as getting ready to start. So I just want to show you this picture because it's exciting, and please don't try to write any of this down. But this was a review last year that tried to tell us all of the compounds that are in clinical trials for Parkinson's disease at this time. So pretty exciting wheel of drugs there, a lot of trials, a lot of research going on. We're so thankful for that because there's lots of neurological conditions where sadly we have very few drugs in the pipeline. So this is a very robust pipeline. These are all three phases of study, phase 1, 2, and 3 before it comes to market. And so I'm going to highlight, we could be here all week if we were to talk about all of these, but so I want to tell you about some of the more exciting treatments. So first, let's talk about some of the symptomatic therapy for motor symptoms of Parkinson's. If we look at early phase Parkinson's, meaning, usually the first 3 to 5 years of the there's 3 interventions that are in study and that we do have some results on as well. And so I'm going to talk about these 3. Tavapadin is a selective dopamine receptor agonist. So we are plagued by the problem with a lot of our medications where they stimulate all the dopamine receptors, D1, 2, 3, 4, and 5 in the brain. But we really only want them targeting certain D receptors. And the D2 and D3 in particular can get people into trouble with side effects and other issues. So this compound is selectively only binding to D1 and D5, not to D2 and D3. So the hope is we get the motor benefits without all the side effects that we typically see with the dopamine agonist drugs. So some of you may be aware of Pramipexole or Mirapex, Ropinirole, Requip, and the patch, which is Nupro. Some of these drugs can be difficult to tolerate because of side effects. We're hoping this particular product will change that for us. And it's currently in ongoing trials. The Tempo 1 and Tempo 2 studies are ongoing. They're phase 3 studies, so they're near the end. The phase 2 study was just published. It was a 15-week trial and showed great motor improvement without those side effects. So it's progressing very well through the clinical pipeline. There's a product called P2B001. This is a combination of Pramipexole and Rasagiline, two drugs that are already on the market. But the idea is that we put the two together at lower doses so that combination may be beneficial for early Parkinson's patients without the side effects of using one of the drugs at higher dosing levels. And so this is going through a phase 3 study. They're hoping to recruit about 523 patients to test this product in early Parkinson's disease. And then exercise, you've heard a lot about exercise today, but there's actually the Sparks 3 trial ongoing now. It's a multi-site randomized trial. They're looking at treadmill exercise, and they're taking patients up to different heart rate percentages. So they're comparing treadmill exercise going up to 65% increase in heart rate versus an 85% increase in heart rate 4 times a week. And of course, intuitively, we would think exercise is going to be helpful and good for these patients. But what this trial is trying to look at is, does it slow progression? So if we have a certain protocol of exercise, will it slow progression? Because these patients are not on Parkinson's medications to be in the trial. So we're just getting a direct look at exercise without the influence of medications. Okay, now moving to trials for more advanced Parkinson's motor symptoms. There's a lot going on. This is a list of not all of them, but the majority of the impressive therapies. Some of these are already out on the market, like the inhaled levodopa, Inbrija, and the sublingual Kinmobi, which are up there in the top left. But in trial, we have some longer acting preparations of dopamine in the pill form, the IPX203, for example. We have pumps that are in trials that I'm going to talk about. We have a DopaFuse device I'll tell you about as well. And then we have some add-on drugs over on the right side of the screen that help the dopamine, including a trial that's looking at cannabis as a potential add-on therapy as well. So let's talk about longer-acting oral levodopa. We recently completed the IPX203 trial. This drug is carbidopa-levodopa, which you are all familiar with, but it's putting it in a capsule that lasts longer. And the hope is that it would last 12 hours. We didn't quite find those results to be exactly 12 hours. Many patients were wearing off short of 12 hours, but they certainly were getting longer-acting benefits, even longer benefits than you can get with the controlled release forms, such as Rytari and the controlled release carbidopa-levodopa. So this is sort of the next step, hopefully, in a longer-acting, longer-lasting dopamine pill. The company is also in production of a 24-hour capsule of carbidopa-levodopa. So if that one makes it through, we're going to be really excited to be able to have more stable levels orally with medication instead of these ups and downs and frequent dosing throughout the day. So our site completed a subcutaneous pump study by Neuroderm, where liquid carbidopa-levodopa was infused through an external pump on the outside of the body to under the skin through a little patch that gets applied to the skin. And the trial, the FDA came back to the company and said, well, we need a little bit more study on this product. We need another study, basically. And so they've added the Beyond study, and they're looking at different dosing, and they're looking at placement of the infusions on the body to give optimal levels of medication. But this is an exciting area to think about leveling off the dopamine levels and eliminating the ons and offs with a subcutaneous infusion given over 24 hours. Competing with them is AbbVie. AbbVie has also a subcutaneous infusion pump. They are using a version of levodopa called phoslevodopa. This changes the way the levodopa is absorbed and perhaps the way it'll affect patients in a positive way. We just concluded their randomized double-blind placebo-controlled trial, and those patients have now moved into an extension study, so they continue to wear the pump for the next 2 years to monitor how they do with it and to look for side effects and gain more information. AbbVie came out with a press release just a few weeks ago announcing the positive results from their trial. We don't have those actual results in our hands yet, but they're soon to be released. But they're giving us a preview saying they were good. They were positive results. AbbVie, of course, has the current pump on the market called Duopa that stomach and supplies a gel of carbidopa levodopa. So this will be their second generation subcutaneous route instead of into the stomach. So hopefully they'll be applying for license soon to bring it on the market. The DopaFuse system, this is a retainer it's customized to fit, and on the retainer is a little cell that contains levodopa. The levodopa, once it's in the mouth, is dripped on the back of the tongue. You can't taste it or even feel it. It's such a small amount being dripped in the back, but it's a continuous infusion of dopamine. And again, the idea is you would wear this for days at a time and not have to take oral medication while you're using this product. It's still in early phase development. It's been moving a little bit slow right now, mostly because of COVID problems with research centers, but still moving along. And there's a number of medications that are in the pipeline to address the problem of dyskinesia, the involuntary movements that some patients have. And this is a list of the ones that are currently in trial. I won't go through each one, but I want to let you know that the third one down by a company called Addicts is a trial that we are getting ready to open here in Tulsa. So we're excited to join that trial to look for another product to help suppress dyskinesias. Patients who come into that trial can stay on their regular medication. They don't have to change anything, but this treatment would be an add-on to try to suppress those involuntary movements. And then this is another one that I just wanted to bring to people's attention because it's a dopamine D3 antagonist or blocking drug. I just told you a little bit about those different dopamine receptors. And it turns out that the impulse control problem that some of the drugs may cause patients, like gambling addictions and eating and substance use and whatnot, from typically the dopamine agonist drugs for Parkinson's, it seems that the mechanism of that is this overstimulation of the D3 receptor. So they have now created a D3 receptor blocking drug, and they didn't bring it into the clinical trials to treat impulse control problems. It's actually trying to treat some of the motor symptoms, the dyskinesias and the ups and downs. But we're excited to see, will this also help some of these other non-motor problems that we're seeing? And interestingly, drug addictions and alcoholism may also be part of this D3 receptor reward system. So we could imagine that this might be a compound someday that helps to fight some of those drug addictions as well. So an exciting compound that we're watching closely. And then there's a number of pharmacologic and non-pharmacologic interventions to help with gait and balance. There's some studies looking at physiotherapy, using dance therapy along with physical therapy, using virtual reality technologies to try to help with balance and gait disorders, especially freezing of gait. Exercises using cueing with either visual cueing or auditory cueing. And then there's some medications, including the cholinesterase inhibitors that are used for Alzheimer's disease, for memory problems, might also have a benefit for gait and balance. So those trials are ongoing. They're even looking at targeted exercise programs, looking at balance exercises together with a walking program versus just a walking program alone, or using a dance program together with physiotherapy and Parkinson's to see if those combinations might be beneficial. So they're trying to tease this out so that we're not just saying, go do exercise, and there's all these different classes you can go to, but we don't know which one is good, which one is helpful. Try them all, go to all of them. We're trying to be more scientific about which ones may help certain problems and be more helpful for each of you. Okay. And they're even doing studies, aqua stand-up paddleboard for balancing, just all kinds of interesting things in the pipeline to help with balance. I don't think I could stand on a aqua board either, but I want to tell you about this is for non-motor symptoms, so cognitive impairment. We have started a new product, a trial of a new product called NYX-458. This is a company by the name of Aptonix. Aptonix found a receptor in the brain that they think is uniquely affected by Parkinson's disease, leading to some of the cognitive challenges and possibly even to the dementia that occurs in Parkinson's disease in some people. So for this study, you can have just mild cognitive symptoms developing, or you can have all the way to a quite advanced dementia of Parkinson's disease and qualify for this study. We're looking at this oral medication taken once a day to see if it might influence the cognitive challenges. So the trial itself has a lot of cognitive testing that we do in the office, as well as safety testing. It's about a 3-month-long study, so it's not super long, but it hopefully will give us some more information about the potential benefits of this product. It's in a phase 2 study. Okay, this I thought was an interesting study. This was published within this last year. And of course, this is sort of developing, I think, with all the virtual and Zoom meetings that we've had to do with COVID last year. But they looked at a telephone-based cognitive behavioral therapy. So the therapist connects by phone to the patient who is dealing with major depression, with Parkinson's. They go through 10 sessions on a weekly basis for the first 3 months, and then they have a monthly session for the 6-month follow-up. And this cognitive therapy is teaching patients how to change their thinking and change their behavioral practices as it relates to depression symptoms. It's a very regimented program, it's scripted, and so they ran this trial to compare this type of therapy with just treatment as usual. So whatever the patients were doing otherwise, they compared that group to the telephone-based treatment. And this graph shows quite a dramatic difference between the groups. The top line, those patients continue to have the same level of depression with treatment as usual. But the red line, they saw dramatic improvements in the depression scales over this time point. And then when they stopped the therapy and checked them 6 months later, there was continuation of those benefits even at 6 months. So the idea is we might be able to develop these type of interventions that can reach out to people in a home-based effort and help with some of the burden that it takes coming in and out of the clinic and so forth. All right. This study was looking at exercise and how it might help people with sleep in Parkinson's disease. They looked at 27 patients that were receiving exercise versus 28 patients who were just taught how to have better sleep hygiene. And the exercise group was exercising 3 times a week for 16 weeks. And then they all had a formal sleep evaluation done with polysomnography to see their sleep efficiency. Are they getting into different stages of sleep? What's their REM sleep like? So very detailed analysis. And the bottom line on this graph is that the exercise group performed significantly better in just about every sleep measure that they looked at compared to the non-exercise group. So exercise is helping more than just our muscles and our cognitive abilities and our mood. It's also leading to better sleep hygiene as well. Okay, now I want to go to the neuroprotective trials. This is, I think, the most exciting. It's what really gets me excited every day in the clinic is this missing piece that we have where we have no ability in the pharmaceutical world right now of slowing the progression of Parkinson's disease. We can treat symptoms, certain ones, but we have nothing to offer to slow down the progression. And that's what we're desperately after right now. Because we're faced with this reality, over time, Parkinson's is spreading, and the Brock stages are shown here. It starts in the brainstem and then can move north into the higher thinking cortex area of the brain. And it can do so in different patterns and different speed. Some people will have dementia because of that spread, some will not. So it's highly variable. But the bottom line is we want to stop this spread as early as possible. And there's many directions at looking at how we can potentially slow this process down. We know that the Lewy bodies are the pathology moving and causing the problems throughout the brain. So one way to maybe do that is to get rid of the Lewy bodies, to grab them as they're moving from cell to cell and removing them so that they can't go infect another cell. So we recently wrapped up what was called the Pasadena trial. This is a vaccine that was developed by Roche. There was a few companies that developed a vaccine. Unfortunately, the Biogen vaccine failed in its recent trial, so it's been removed from clinical trials. But the Roche vaccine continues to hang in there. And this was a phase 2 study. It was a global international study that we were grateful to be a part of. And it showed a 35% improvement in motor scores in early Parkinson's disease patients who were not on any treatment at all for Parkinson's. So looking at these secondary markers like imaging markers and some of the clinical skills that we used in the office, we saw a definite difference between what was happening in the treatment group versus the placebo group. So this was very encouraging. Interestingly, we got better results from the lower dose than the higher dose. We don't know why. So the next study that has just started, called the PADOVA trial, is just looking at the lower dose. And they're basically repeating the Pasadena trial. So this is an international study. We're trying to internationally recruit over 500 patients for this study. And again, it's looking at this vaccine treatment versus placebo for the first year. And then the second year, everybody receives the vaccine. So everyone gets a chance to be on it. And then the hope is that there might be an opportunity to continue using it after the trial is over. But it's called the PADOVA trial. We're openly recruiting patients for this. The Pasadena trial, the requirement was you could not be on Parkinson's medication to qualify. But with the PADOVA trial, you can only qualify if you are on Parkinson's medication. So in this trial, they want people on carbidopa-levodopa or an MAO inhibitor like Azilect or selegiline to qualify for the trial. But you still have to be in the early phases of Parkinson's. You have to be in the first 3 years to qualify for the trial. But our hope is if this works and it comes to market, we can use it at any stage to try to slow progression. So we have this vaccine in development. Another way we can try to get at this, to get those Lewy bodies out of the brain, is to try to create an opportunity for our own immune system to make antibodies to attack the Lewy bodies. So this product called, that's being made from Ephyris, this product, PD01A, has been in clinical trials, and it's a protein segment. It's kind of like the more traditional vaccine approach where you give a fragment of a virus to a patient, they make antibodies to that virus, and now they have immunity to that virus. So it's the same idea here. We're giving the alpha-synuclein bits of that protein to tell the immune system to make an antibody to it to get rid of that protein. And so they found in the first study that was just published a 50% reduction in the pathological alpha-synuclein protein. So very exciting results from this first study. It does require a booster at 1 year and then again on a yearly basis, but they're still studying this product to see how it's going to do and to gather more safety data. So it's making good progress through clinical trials. Okay, so I want to just talk about one other aspect. There's some studies that have looked at diabetes, type 2 diabetes, and Parkinson's disease. And this was a study that was published in the Journal of Neurology recently. They looked at a database of 2 million people with diabetes and 4 million people with no diabetes, and then looked at, through their lifetime, what was the risk of developing Parkinson's disease between those two groups. And they found that the people who had type 2 diabetes had a 30% increased risk of developing Parkinson's disease. So then they said, well, let's look at what treatments those individuals were taking. So this was a different database called the THIN database. They had 15 million people in this database. They selected out 100,000 people with diabetes, and they looked at what drugs they were taking through the whole course of treatment of their diabetes over their lifetime, and then looked at the risk of developing Parkinson's based upon the drugs that they were taking for their diabetes. And something interesting was found. There's a drug class that modulates something called GLP-1, and they found about over half the risk of developing Parkinson's disease if those diabetic patients were taking one of those products to treat the diabetes. So that sparked a trial looking at a product called exenatide, which is a diabetic treatment. It's an injectable medication taken once a week. And they compared two groups, one on placebo shown in the red on the top, and then the exenatide group on the bottom. And what was interesting in this particular study that they just published, they saw in the first 12 weeks an actual improvement in the Parkinson's symptoms, which they were not expecting. You wouldn't think a diabetic drug would help Parkinson's symptoms, but they found that. And then it stayed very stable over the course of the 48-week study. At the end of 48 weeks, they had to stop the treatment. And so during the washout, they finally reevaluated them at 60 weeks. The group did not catch up to the placebo group, which was continuing to get worse. So there seemed to be a neuroprotective benefit. They were still doing better than the group that had not received the treatment through the whole course. So this was an earlier phase study. Now we're doing a phase 3 study. That's an international study. The earlier studies were done in Europe, but now they're adding sites here in the US and in South Korea. And we're excited to say that we're one of the sites testing this therapy here in Tulsa. So the PRISM study is the trial that's now open, looking for patients who want to explore this opportunity to try to slow progression. And again, for the sake of time, I can't go through all the compounds, but this is another list of neuroprotective drugs that are in trials targeting different aspects of the neurodegenerative pathway, including looking at things like the microbiome with probiotics, using immune cell therapies and whatnot. So it's a rich pipeline, very exciting time. And so the last slide here is just to show you, these are the trials that we currently have open. We have the PADOVA trial, the PRISM study, which is the diabetic drug, We have the orchestra study. It's another neuroprotective study for early Parkinson's patients who are not on treatment to try to slow progression. The Aptonix trial for cognitive impairment, a pump trial that is now opening up again for AbbVie, and then the dyskinesia study. And we're hoping to get a go-ahead from Sun Pharma for another product to try to slow progression using the BRCA-ABL pathways. So lots of things going on in our clinic with research that we're excited about, and we're continuing to work hard on these to try to get better treatments to all of you eventually. So again, thank you for your time and attention. Sorry it went long, but thank you so much.
Well, thank you, Dr. Klos, for being so generous with your expertise. Thank you to all of our speakers today, to our sponsorship partners, and thank you, whether you're the patient or the caregiver. We encourage you, keep going, keep up your curiosity, your determination, your resilience. As we often say, you may have Parkinson's, but Parkinson's is only part of your story. Parkinson's doesn't have you. Keep going, and we'll see you along the way. Thank you.